Hey y'all, welcome to my Exam 3 Essay 1 video. If I look and sound like garbage, it's because I do kind of have like a viral cold right now, so don't judge me, okay? Now, so let's adjust that just a tad here. Yeah, let's do that, okay? So we're going to be talking about the cardiovascular system a little bit, and first we're going to start with the autorhythmic cells. These are cells that are typically located on your SA node of your heart. And so we're going to talk about that first, kind of how they function, what they do. So generally, what's going to happen with these autorhythmic cells is they have a channel called an HCN channel. What HCN does is it responds to hyperpolarization or cyclic nucleotides, or CAMP. Okay, so generally what's going to happen is your action potential is going to hyperpolarize, and that's going to open up this channel a little bit, okay? And now what that's going to do is you're going to have, usually it's sodium, is going to rush into this cell, okay? Sodium's going to rush in, and then that's going to charge or cause an action potential or voltage change to come over, actually, excuse me, yep. So that's going to cause a voltage change, and it's going to activate this voltage-gated calcium channel. Now there's two types, there's a T-type and an L-type. The T-type opens and closes pretty quick, and L-type takes longer lasting. Now usually we're just going to worry about the L-types for now, okay? So this L-type channel is going to open up, and then calcium is going to rush into this cell, okay? And essentially once that happens, what's going to happen is just kind of the same as skeletal muscle. It's going to activate this RYR, that's going to open up, calcium's going to rush out, so you have some calcium in the SR here. Calcium's going to rush out, cross-bridge cycle is going to happen, myosin's, right, this calcium's going to bind to troponin, troponin's going to pull away tropomyosin, which is going to expose some myosin active sites, or some actin binding sites. Myosin's going to bind to those sites, and then you have power stroke, and it's going to have that same cycle. So that's essentially what happens to an autorhythmic cell normally. Now, what happens is we have that action potential is going to travel. So this cell, it's kind of branched out to other muscle cells, other cardiac muscle cells, myocytes. Cardiac myocytes are contractile cells, and those are the cells that are going to kind of get the blood pumping. It's going to activate that heart rate, or not the heart rate, the heartbeat, and that contraction there. Essentially, the autorhythmic cells, what it controls is something called chronotropy. Now, chronotropy is something to do with time, which is about how many beats your heart gets within a given time, okay? So that's what's going to happen there, okay? So it's going to kind of set your chronotropy, or how many beats per minute you're going to have, okay? Now, let's see what happens when we activate different receptors with this one. So we're going to switch over to red. Now, let's say you get some norepinephrine. It's going to bind to this beta-1 receptor, which is connected to G protein. Now, that's going to do is it's going to activate it. Its alpha subunit is going to come in, and it's going to activate adenyl cyclase, okay? Now, what adenyl cyclase does is it's going to, I know what it is, but, okay, it's going to release CAMP. Okay, now what do we know about CAMP? Is our HCN channels responds really well to CAMP. So it's going to go over and it's going to activate those HCNs even more, which is going to allow more sodium to rush into the cell, okay? Sorry, let me catch my breath here. What also happens is CAMP, it's going to activate protein kinase A, or PKA. Now PKA, it's an enzyme that just likes to go in and phosphorylate everything. Okay, so what it's going to do is it's first going to phosphorylate these voltage-gated calcium channels, okay? So now more calcium, because more channels are being opened and activated, more calcium is going to rush in, okay? And then what that does, what also PKA does, is it's going to go to our RYRs, and there's a little protein on it called calstabin, and it's going to essentially inhibit calstabin so that RYR gets activated even more, okay? So what happens, our RYR gets opened up even more calcium is going to rush out. It's also going to go to our circuit pumps. Circuit pumps have another protein attached to it called phospholambin. It's going to inactivate that phospholambin. Circuit pump activity is going to increase, so more calcium is being cycled back into the SR. Okay, so now let's think about that, what that's going to do to our chronotropy, and what it's going to do to our action potential of our autorhythmic cells. Now it's a little different than like a normal skeletal muscle. You have different phases. So here we have phase 4, phase 0, and phase 3. So what happens, phase 4, that's when that HCN channel gets activated, and it's going to open up, and then once it reaches threshold, it's going to be at a negative 60 RMP. Oh, excuse me, sorry, I just feel like crap. And so it's going to increase, and once that gets to threshold, that's when those voltage gated calcium channels, so then we're running off that calcium current, and that gets us through phase 0 to our depolarization and the peak of our action potential. And then eventually what's going to happen is that voltage is going to change so much that it's going to activate these potassium channels, and now those potassium channels, now we're going to have potassium leaving the cell, and that's what repolarizes it. So then we go off the potassium current, goes down below threshold, and then we just keep going. It's very rhythmic, it just keeps going, so it sets the tone like that. Okay, but now imagine this. So norepinephrine binds to beta 1, it's excitatory. So then what happens is now we have CAMP is being released, so more HCN is being activated, which means more sodium is being brought in. So our phase 4 is going to be a lot steeper. And now we have pKa, which is going to activate more calcium. So now more calcium is going to rush into the cell. So our phase 0 is also going to be very steep. Then we're going to have more of a rapid change here, voltage change. Then our potassium is going to leave sooner. So then we're going to have a way steeper phase 3. And then we're just going to keep going. Another thing that's going to happen is because we have increased calcium here, we're going to increase or make our threshold more negative. So now we have more of these action potentials, and they're more rapid. So we're just going to see more of these. So we have more heartbeats per minute, so our chronotropy is going to increase like that. Okay, so just think about the pathways here. This is essentially on the textbook, all those flow charts, that's what they mean. Okay, but our autorhythmic cells, they also have another M2 receptor. M2 is inhibitory. So now we're going to have acetylcholine, right, because it's muscarinic, so acetylcholine is going to combine. Excuse me, and our alpha subunit is going to come, and it's going to inhibit adenyl cyclase from activating. It's going to inactivate CMP and inactivate pKa, okay? So none of that's going to happen. So we're essentially going to be kind of at normal, but what also happens is on that G protein, our beta and gamma subunits are kind of intertwined. So it makes what's called a heterodimer, and this heterodimer goes over and activates what's called a GERT channel. Now a GERT channel is just a potassium channel. So now we're going to have lots of potassium leaving the cell. Okay, so that's essentially what's going to happen. So we're going to have less calcium now, kind of less everything here. So what that's going to do here is going to make our threshold more positive. Now not as many HCN channels are being activated, so it's going to be a lot flatter slope. Because of there's no pKa, not as many voltage gated calcium channels are being activated, so our phase 0 is also going to be a really slow slope. And it's going to kind of have, or this is kind of running off of, our phase 3 is running off of potassium current. It's going to repolarize a lot quicker, but then it's kind of just going to go through the same thing. So what we did is we decreased the amount of heartbeats per minute. So with that, with our M2 receptors, we decreased our chronotropy. So again, think of all this here and how that all works, okay? And according to those flow charts and pathways, okay? Now let's move to those contractile cells we talked about. Now remember, our contractile cells are branched off of our autorhythmic cells, or our nodo cells. And so once they receive an action potential from those, what it's going to do is it's established its RMP at -90, and it's maintaining that through potassium currents or potassium channels. This action potential from the autorhythmic cell comes in, you're going to see a slope in phase 4. It's going to hit threshold, and what that's going to do is it's going to activate these sodium channels. Okay, so an action potential comes, hits these sodium channels, activates them. So we're going to have sodium, it's going to rush in, okay? Sodium rushes in, so now our phase 0, it's running off with a sodium current, or sodium channels, and it's going to depolarize super quick, and then right at this phase 1, this is called rapid repolarization. So it's going to repolarize super quick. Now I didn't draw them up on this drawing, but what's going to happen is now we have what's called ITO1s, channels open, and that's a potassium current. So now potassium is going to be leaving the cell, which is going to repolarize it. And then we also have ITO2 channels, which are chloride channels. So now chloride is going to be coming in, and so it's going to repolarize even more. But remember, we have kind of those voltage-gated calcium channels. So essentially the same thing happens here. This is our autorhythmic cell. We activate sodium channel, sodium comes in, that voltage activates these L-type calcium channels. Those open up kind of around the same time here. Allowing calcium in, we're going to hit SR, activate RYR, activate circuits, go through that same cross-bridge cycle. It's going to cycle back through the circuit pumps, and bam, that's how contraction happens, okay? So the current of the potassium and chloride channels isn't enough to overcome the calcium current. So we need a little bit of help. So in phase 2, that's called a plateau phase. That's where we're just kind of stuck at a certain charge because we can't overcome this voltage-gated calcium channel current, okay? So need a little bit of help. Same thing, I didn't draw them on this just to keep it simpler. We're going to have some IKUR channels, which means ultra rapid potassium channels. So we're going to open up super quick. Potassium's going to flood out. Then we're going to have IKR channels open, which is rapid channels, so they don't open as quick as the ultra rapid. Same thing, potassium channels. And then we're going to have our RKS channels open, which is potassium slow. And then that's going to kind of help it a little bit more to kind of overcome that plateau and that calcium current. And then we're going to have our IK1s open up. So this is going to open up. Potassium is going to rush out of the cell. And that's going to get us through our phase 3. So phase 3, again, it's based off of potassium currents and potassium channels. So to get us down below threshold, it's going to relax, and then eventually we're going to go do the same thing depending on how the autorhythmic cell is activated. Whew, okay, but our contractile cells, they also have what's called beta-1 receptors. Or we know what beta-1 receptors are, but it's got beta-1 receptors. So we're going to see what happens when we activate those receptors. Now, one thing to remember about contractile cells is they control two kind of concepts called lusitropy. And what lusitropy is the speed of relaxation. So essentially how quick you're able to overcome this plateau phase here, okay? And inotropy is our force of contraction. So essentially how hard that cell is contracting, okay? So now we're going to have, again, we're going to have some norepinephrine, or PI, I guess. Norepinephrine is going to bind to this beta-1 receptor, which is excitatory. Its alpha subunit is going to do the same thing. It's going to activate adenyl cyclase. What adenyl cyclase does? Increases CAMP. Now CAMP, it really doesn't do anything else here except for activate PKA, okay? And then we're going to kind of go through the same thing, okay? Or PKA, it's going to activate these voltage calcium channels even more. So we're going to see an increase in calcium, okay? It's going to, again, activate our RYR more by phosphorylating that calcitatin. And it's going to phosphorylate phospholamban on the circuit pumps as well, okay? What it also does is we have our troponin from the cross bridge. It's going to mess with those, and it's essentially going to kick off calcium super quick. Okay, so again, we're just kind of rapidly going through this cycle. Okay, this increased calcium affects our muscle contraction a lot. So it's going to increase, that increase of calcium is going to increase our ionotropy a ton, okay? So what that does is now we're going to have kind of a steeper phase 4, and then just an absolute rapid phase 0. Excuse me. And with that voltage, again, it's kind of going to go through this super rapid, that repolarization phase. And now, because we have increased circa and that troponin is kind of being inactivated, we're going to have kind of some decreased calcium in that way. We have increased calcium coming into the cytoplasm here. We're going to have decrease from the SR. Or I guess, yeah, kind of decrease going back into the SR. So what that does is it shortens our plateau phase quite a bit because there's not as much calcium current to overcome. That's going to depolarize, it's going to activate those potassium channels a lot, and then bam, we go through it again, okay? So what that does is because of our circuit pump activation and the troponin being deactivated, we see increased lucitropy, which means faster relaxation, which means decreased plateau here, okay? So that's all we need to know for that, and kind of those flow charts, kind of go through that. So now let's move on. We're going to talk about EKGs now. What all happens there, okay? So essentially what the EKG is measuring is how well your heart is depolarizing and repolarizing, okay? How much your heart is kind of being activated is another way to see it, okay? So what's going to happen, and we'll keep it simpler. You have this SA node. SA node connects to your left atrium via Bach or Lockman's bundles or fibers. One of those two, okay? And just because your heart kind of needs to go in pairs, go simultaneously, so your atria, they need to contract at the same time, your ventricles need to contract at the same time. So that kind of helps that happen. It goes down to our AV node via what's called a bundle of His. Goes down to the AV node. The AV node connects to what's called Purkinje's fibers, which goes around our ventricles here, okay? So now, first thing that happens, we gotta understand what happens is if we draw like a row of cells here, if these are kind of getting depolarized, we're gonna have a positive sensor here and a negative sensor here. So we're gonna have a negative tail heading towards a positive center. Well, that's gonna happen is it's gonna cause our wave to go draw up. But eventually it gets to the point, it's about halfway, is when we're kind of at the peak of that. And then what happens is we're having less separation of charge. And so eventually there's more negatives than positives, and because that come back down, back to baseline, okay? Now say we had a negative tail here and it was going towards the negative, well, that's gonna happen, is it's gonna draw down, okay? Because negative can't really go towards negative, like if you think about batteries and magnets. Can't really do that. Again, about halfway, it's going to be kind of the peak there, and it's going to climb back up to baseline, okay? So that's kind of the concept of EKGs you need to remember. In its simplest form. Oh, holy crap, this sucks, dude. I feel like garbage. Okay, so be nice to me. Don't be judging me when you're watching this. Like, this dude looks like garbage. I don't know how he ever got married. Looks like trash. It's because I'm sick, okay? This would be nice. Don't have pity on me and either give me extra credit, whatever crap. I don't need it. I can earn it myself. Oh, okay. So now let's go here. In our SA node, it's going to cause our Lockman bundles to activate our left atrium. And those are going to kind of depolarize at the same time, our atria. Okay. So it's going to cause that same kind of hump there that we showed here. And this is what's called our P wave, okay? Now our P wave is just depolarization of our atria, okay? And it's going to kind of flatten out there. And then what's going to happen is our left ventricle, it's kind of thicker, like its myocardium's a bit thicker than the right. So it's going to depolarize right here, what's called the superior lateral ventricular septum. And it's going to kind of cause a vector. So it's going to have a negative tail still, but it's going to go towards our negative, right? So we have a negative here, positive here. Our vector for our atria, it was going straight towards our positive with a negative tail. Oh, excuse me. So if that's going to happen, what's going to happen is it's going to draw down, right? Because we're going towards a negative tail, or negative sensor. It's going to spike down, come back up. This is called our Q wave, okay? So that's just depolarization of the superior lateral ventricular septum. Okay, and then that's going to activate all these Purkinje fibers around the ventricles. So we're going to have some crazy depolarization of these ventricular walls. Here, again, it's a straight up strong vector, negative tail to a positive sensor. So that's going to shoot up, and this is our R wave, okay? So R is, it's going to come back down again. Our R wave, depolarization of the ventricles. But remember, our left is a bit thicker, so it kind of needs a little bit more work. So we're going to have those ones are going to kind of depolarize. It's going endocardium to epicardium, and depolarize that way, and kind of head more towards a negative sensor. So it's negative tail heading towards a negative sensor. So what happens there is now we're going to have, right after the R wave, we're going to have a big downward spike and back up. This is called our S wave, okay? S wave is just depolarization of the left superior lateral ventricular wall, okay? It's going to plateau. But again, if we want another action potential to happen, if we want this to depolarize again, we're going to need some repolarization. So depolarization occurred epicardium to endocardium. Now from epicardium, we're going to have a positive tail. It's going to go towards our negative sensor again. So then positive towards negative this time. That's going to repolarize the ventricles. Now by this time, the atrium are already kind of repolarized, but our ventricles need to repolarize, so it's going to go up. It's going to have another little hump like that. And this is our T wave. So T wave is just repolarization of the ventricles. Okay? Holy cow. Okay. So that's essentially how that works. Okay? So let's see. Let's try to kind of clean up this section here. Now we're going to talk about some abnormal EKGs, specifically STEMI and non-STEMI. Erase this here. Okay. So we're going to have a coronary artery. It'll come in, it's going to kind of taper up. Now, that's what's feeding kind of the heart tissue. So let's say we had kind of a blockage here. What that's going to do is a little bit of this endocardium is going to become hypoxic, okay? Now it's got a bit of a defense mechanism, so it doesn't do that. All your myocytes are going to have kind of your sodium potassium pump, right? But if there's no oxygen, there's no ATP, which means that's not really working. So when that happens, is ATP, what that's doing is it's kind of holding close. It's called a KATP channel. So if there's no ATP, then that's not being held close, so that's going to open, and potassium is going to kind of go out. So that's so we can avoid abnormal EKGs. But sometimes it's not able to overcome how repolarized this stuff is, or how hypoxic it is. So if you have a little bit of hypoxia here, so now when we're repolarizing, now this part, we're going to have kind of a epicardium. It's supposed to repolarize epicardium to endocardium, but now that's going to have more like a endocardium to epicardium repolarization. So it's going to kind of cancel out each other, make everything weird. So then kind of our EKG is going to have a normal P wave, normal Q, normal R, normal S. Then this T wave, because it's kind of reversed, it's going to invert. And that just represents some mild hypoxia of our epicardium, which is not good, okay? We're on the upward climb to a heart attack, okay? So now let's erase this. Normally your heart's got some, like a baseline for what it wants. So that's where it kind of wants to be. So if this got worse, So it's not quite all the way through the myocardium there. It just got a little worse. You're going to have what's called a background current of injury, okay? So you're going to have kind of like an increased baseline here, okay? So you have this increased baseline, so your P wave, your Q wave, your R wave, and your S, those are all going to kind of occur at this new baseline set by that current of injury. Now our S, that's when the ventricles are repolarized. This is everything repolarized. So this is going to kind of like not be seen on the S wave. So that's going to go down to our normal baseline, what we want. But then, because this is still like repolarized, you're still going to have some weird stuff going on with the T wave. So that's going to happen. You have vectors kind of canceling each other out. So you have kind of like this weird slope, and then your T wave. Okay, so when you have that, that's called an ST depression. Okay, so that means that hypoxia is getting worse. He's going to have a heart attack soon. Or really, he is having a heart attack right now. Okay, but it can get even worse. Okay. So now this is completely through all of our myocardium there. This is what's called a transmural myocardial infarction. It means it's gone all the way through the myocardium into the epicardium. So what that does is now even more of these are repolarized. So now we have a decline in baseline. Okay. I didn't explain that super great, but just know it's kind of the same concept. This was just, a little bit repolarized, so it's still kind of climbing up. Now it's really, negative. There's less separation of charge, so now it's going to come down the baseline. Okay. So now our baseline is here. Again, P, Q, R, and now our S. Again, it's repolarization of the ventricles. That's just going to go down to our original baseline. And then it's going to kind of get weird again. It's going to have this weird decline to our T wave. Okay, so this is called an ST elevation. So essentially your S wave is above your baseline. Okay, so that is what's called a STEMI. So that's a really bad heart attack. You need to get to the ER, emergency surgery. Okay. What we did before with the ST depression, that was called a non-STEMI or an NSTEMI, which is just not a STEMI. Okay, it's not as bad. Okay, that's pretty much it for EKGs. Now, excuse me. Holy frick. All right, kind of last concepts we need to go over. It's kind of like the cardiac cycle, kind of how blood, pressure, volume change. Oh, okay. Yeah, okay. All right, we got it. Okay. So essentially what's happening here is this is kind of how our pressures with time kind of correlate. Okay. So imagine this black line, that's our left atrium. Blue lines are left ventricle, and our red lines are aorta. Okay. So what's going to happen is in your heart, the left atrium, there's going to be some blood flow into the left ventricle, just passive flow, because there's these pressure gradients, right? Our left atrium pressure is higher than our left ventricle pressure. So it's going to kind of decrease there. And then eventually, so this little hump here, that's when the atriums kind of contract. That's what gives it that final push to where now our left ventricle pressure is higher than the left atrium pressure. What that's going to do is it's going to slam that mitral valve close. Okay, and that close of that AV valve, that's your lub sound. When you're like listening to someone's heart, it's like lub dub, lub dub, lub dub. Or if like this valve isn't closing properly or it's kind of whack, you'd be like lub sh dub, lub sh dub. But normal is like lub dub, lub dub. That's our lub sound there. Okay. Okay. So then when that happens, now our pressure for our ventricle, that's just going to skyrocket because that's closed, no blood's leaving, that pressure is just going to increase. And this kind of section here, that's called our isovolumetric relaxation, contraction. So that's when that ventricle is kind of contracting, getting that pressure higher. So it's going, kind of getting the pressure higher, higher, higher. Now here, this is kind of our volume via time. So what we saw over here is what's called diastole, which is ventricular relaxation essentially. And there's 3 stages of it. You have rapid influx. So that's just when the pressure gradients are so different, you're just gonna have some passive blood movement down into that ventricle. So that's where the majority of the blood volume for the left ventricle comes in, is that rapid influx. You have diastasis, and that's where it kind of plateaus. There's still some blood coming in, but again, that pressure gradient is just getting more and more less steep. So not as much blood's gonna come in. And now we're gonna have that atrial contraction right here, which is this little hump. So a little bit more of a hump of volume, which is gonna get it there. But notice here, our volume, it's not changing with our isometric contraction here. The pressure is going up, but our volume is staying the same because no more blood's coming in because our mitral valve is closed. Okay, so again, kind of like right here, this is where that mitral valve closed. That's our lub sound. This is our atrial contraction. So then that pressure eventually is going to get so great that it's going to overcome the pressure of the aorta at relaxation. Now the pressure of the aorta at relaxation is about 80 millimeters of mercury. So it's going to overcome that, and it's going to blow this aortic valve, that semilunar aorta valve, and blow that open. So all this volume is going to kind of rush out. This is what's called the ejection phase. Okay, so our pressure, it kind of stays the same, or it kind of has this little bit of a hill. During this ejection phase, when that aortic valve opens and blood's rushing into the aorta, you're going to have our ejection phase on our volume graph, okay? So then the volume in our left ventricle is just going to plummet hard, okay? Eventually the gradient, or I guess the pressure of that aorta is going to overcome the left ventricle, and it's going to close. Now I didn't draw it super well, but you'll kind of see a little bit of a hump with our aorta pressure. That's because once it slams closed, there's a little bit of a pressure wave that kind of hits the aorta walls. It's to increase the pressure just a little bit, and that's called our dicrotic notch, okay? So just essentially measuring how elastic your aorta is, just how it responds to that pressure, okay? So now our pressure for our aorta is going to kind of go to the same. So this section, that ejection, and the ventricles are contracting, that's called systole, which is ventricular contraction, okay? So eventually, now that closes, so now our pressure of our left ventricle is just going to plummet, and it's going to kind of relax. So that, on our volume chart, it's going to kind of stay the same, the volume. That's called isovolumetric relaxation. So then come the same, and eventually our pressure of our left ventricle is going to be kind of our pressure of left ventricle is going to be less than the pressure of the left atrium. So the mitral valve is going to open, and it's going to cause dystole again, okay? Which is when it's kind of the ventricles are relaxing, we're getting the rapid influx, diastasis, and our atrial contraction, kind of those phases. We essentially kind of restart, okay? What I didn't mention is once your aortic valve, that semilunar valve closes, that's the dub. So lub dub, so you have lub dub. The aortic valve closes on the dub. Now if it's like lub dub, that means your aortic valve isn't working very good, okay? Now, that's essentially all we have for today. Thanks for watching. Appreciate your time. Have a good one.